Welcome to our channel. Today, we're diving into the practical management of patients at risk for or with left ventricular thrombus, or LV thrombus for short. As you know, this can be a serious condition, but with the right knowledge and proactive care, we can significantly improve patient outcomes. We'll be covering a lot of ground today, from the role of cardiac MRI in diagnosis to specific treatment guidelines for patients with different types of heart conditions. Our goal is to give you practical, evidence-based advice that you can implement in your practice immediately. So whether you're a seasoned cardiologist or a medical student just starting out, I'm confident you'll find this video informative and useful. Let's get started. Echocardiography is often our first line of imaging when we suspect LV thrombus. But what happens when the picture isn't clear? That's where cardiac MRI or CMR comes in. CMR offers superior soft tissue contrast compared to echocardiography, allowing us to better visualize the left ventricle and identify even small thrombi that might be missed otherwise. Think of it as getting a more detailed look inside the heart, helping us make more accurate diagnoses and treatment decisions. The decision to use prophylactic oral anticoagulation, or OAC, in patients with acute anteroapical STEMI who've received reperfusion therapy is a delicate balancing act. While there's a theoretical benefit in preventing thrombus formation, the data supporting this practice is limited. This is where shared decision-making becomes crucial. We need to carefully consider the individual patient's risk factors for both thrombus formation and bleeding complications. If we do decide to initiate OAC, a short duration of 1 to 3 months is generally sufficient. For patients who've already developed an LV thrombus following a myocardial infarction, the approach is more straightforward. In these cases, OAC is the standard of care. The goal here is to prevent the existing thrombus from growing and to minimize the risk of embolic events. A typical treatment duration of 3 months is recommended to strike a balance between efficacy and safety. In patients with dilated cardiomyopathy, or DCM, the decision to use prophylactic OAC is less clear-cut. For most DCM patients, the risks of anticoagulation outweigh the potential benefits. However, there are exceptions. Some specific types of cardiomyopathy, such as those associated with genetic mutations, can significantly increase the risk of LV thrombus formation. In these select cases, OAC may be considered after a thorough assessment of the patient's individual risk profile. Non-ischemic cardiomyopathy, or NICM, presents another set of considerations. When an LV thrombus is present in these patients, OAC is recommended for at least 3 to 6 months. The rationale for this longer duration is to allow time for the heart function to potentially recover. If the left ventricular ejection fraction, or LVEF, improves to greater than 35% during this period, discontinuation of OAC can be considered. However, it's crucial to remain vigilant for any signs of recurrent thrombus formation. When we encounter a patient with a newly diagnosed mural LV thrombus, it's essential to act proactively. While a mural thrombus might seem less concerning than a protruding or mobile one, it still carries the potential for embolization. Therefore, it's generally prudent to treat these patients with oral anticoagulants, just as we would for those with more worrisome thrombus characteristics. This aggressive approach can help mitigate the risk of serious complications. Direct oral anticoagulants, or DOACs, have emerged as potential alternatives to warfarin in managing LV thrombus. While the data is still somewhat limited, studies suggest that DOACs offer comparable efficacy to warfarin in preventing thromboembolic events. This is encouraging news, as DOACs often have more favorable safety profiles and are more convenient for patients. However, more research is needed to fully establish the long-term efficacy and safety of DOACs in this specific patient population. Sometimes we encounter patients with persistent LV thrombus despite appropriate oral anticoagulant therapy. These cases can be challenging, but there are still options to consider. In some instances, particularly when dealing with a protruding or mobile thrombus, trialing an alternative oral anticoagulant or low molecular weight heparin might be warranted. Additionally, if a persistent mural thrombus becomes organized or calcified over time, discontinuing oral anticoagulants may be a reasonable approach. However, these decisions should always be individualized based on the patient's specific circumstances and risk factors. Thanks for watching. I hope this deep dive into managing LV thrombus has been helpful for you. Remember, early diagnosis and proactive management are key to improving outcomes for our patients. If you found this information valuable, please give this video a thumbs up and share it with your colleagues. Don't forget to subscribe to our channel for more evidence-based medical insights. Until next time, stay healthy and informed.